Hi, everyone. My name is Mako, and I'm a doctoral candidate at UCLA in psychology. And today I'm going to be talking to you about Chapter 9 in the Abnormal Psychology textbook that you're currently reading. This chapter is about sexual disorders, gender dysphoria, and paraphilic disorders. So we're going to unpack all of that together. Before getting into the nitty-gritty, I wanted to give an important disclaimer. And that's that research in psychology, but especially as it pertains to sexuality and gender, is a relatively new field of science. It's completely a product of our time, and as such, it's always changing to reflect a better understanding of this aspect of human functioning. When you're learning about these topics, if something isn't feeling right to you or something doesn't feel like it's forward thinking enough, it's probably because it's not. And who knows, maybe you will be one of the scholars and thinkers who will move our field forward. But I definitely do want to prepare you for that and also let you know that a majority of the research currently focuses on cisgender heterosexual individuals. So this means individuals that identify with the sex they were assigned at birth, and also individuals that date an opposite sex partner. So we'll expect to see most research on that segment of the population. So here's an outline of what we're going to go over today, and this should map on to your textbook. We're going to talk about what is normal sexuality. How do we even begin to make those distinctions? What are sexual dysfunctions, some causes and some treatments of those? Talk about paraphilic disorders, give an overview of that, how they're assessed and how they're treated, and finish off with talking about the experience of gender dysphoria. I also want to define some key terms before we get started that I'm going to use throughout the lecture. And that's because all of us come to this lecture, this recording, with completely different levels of knowledge and experience about this topic. And I want us to get on the same page about these key terms so you can understand the material better. Sex refers to the biological sex at birth. So whether someone is a biological male or biological female or neither or both. Gender refers to the social, psychological, and emotional traits associated with being a man, a woman, a mixture of both, or neither. And sexual orientation is about who people are attracted to. So their emotional, romantic, and sexual feelings towards other people. And this is an abnormal psychology course. So of course, we're first going to talk about how we could even classify patterns of sexuality or gender identity as normal or abnormal. What is the difference between a normal and an abnormal sexual behavior? I want everyone to think very critically about how scholars make this distinction, because there's so much nuance into what is that goes into what is considered normal or abnormal at a certain place at a certain time in history. Currently, the criteria for what is considered abnormal is things like it involves a substantial impairment in functioning. So it really impacts a person's ability to function, or it's really distressing to an individual, or it could involve non-consenting individuals like children. And we also understand a lot about sexual behavior by studying what's typical. So there might be normal or abnormal things that are more or less typical, but how do we know it's typical? We can use normative facts and statistics or information that we gather from large surveys of people to determine what is typical. Although, again, this doesn't necessarily tell us what is normal, because there are a lot of factors to consider. What's typical for men and women can be different. So there are important gender differences in sexual behaviors and attitudes. Even though there are a lot of overlap, if you read through the textbook, they show a lot of examples and how things might be a little bit different on average for men and women, and also important cultural considerations. So if you recall, the textbook had talked about how about half of societies that researchers studied sort of promoted or encouraged or were okay with premarital sex. And then the other half were not okay with it or discouraged it or did not allow it. So what is typical and what is permissible really varies. But if we want to understand like what's typical in a certain society or a certain region, we can collect data and ask people when they do certain things or if they do certain things. And what I'm showing you right here is data from a large scale survey about the prevalence rates for different sexual behaviors. And in the top two graphs that you see, the horizontal or the x-axis is referring to the age of the people that they surveyed. So you can see the age ranges from about 15 years to 22 or 24. And then that y-axis or the vertical axis represents the proportion of people that they surveyed that report having engaged in that behavior. And from looking at the graphs, you can see pretty similar patterns for men and women. So one graph is for males age 15 to 24, and the other graph is for females age 15 to 24. And you can see the patterns, they look pretty similar across both, where as men and women are getting older, they're more likely to have engaged in vaginal intercourse and less likely to only have engaged in oral sex. And then if you're interested in more specific sexual behaviors, you can see the graph at the bottom that has like specific things like anal sex or opposite sex partners. And you can see that pretty much the patterns look somewhat similar between men and women. Now we're going to talk about how people develop their sexual orientations, because this is a really important topic in sexuality research or the psychology of sexuality. We're only really beginning to answer this question, and there is burgeoning research to suggest that one of the influencing factors could be genetics. A common way that psychologists try to get at this biological root of something is by using twin studies. So when you look at a set of twins, researchers have found that 50% of identical twins, and identical twins are the twins that share the exact same genetic characteristics. So 50% of identical twins share the same sexual orientation. And then you can compare this to twins that are not perfect genetic matches. They're also called fraternal twins. And among those twins, about 16 to 22% share the same sexual orientation. So what does this mean? Well, the takeaway from this is that it's more likely that people might have the same sexual orientation, the more similar their genetic makeup is, suggesting that there may be some genetic underpinnings to sexual orientation. But it's so important to note that the genetic component is small, because if you're saying that 50% of identical twins share that same sexual orientation, you're also saying that 50% of identical twins with the same genetic information do not share the same sexual orientation. And those are for twins. So if you look at the data for siblings, so not even twins, you'll see that the proportion that share the same sexual orientation gets even smaller. So genetic probably matters. There's probably a genetic contribution, but you want to be careful with how much you're estimating that to be a factor. In addition to the genetic component, there are other factors in the psychological or social environment of a person that influence their sexual orientation. And this is not like unique to sexual orientation. Almost every aspect of human psychology is determined by some combination of genetic and social and environmental causes. There's no one thing that predicts people's attitudes or behaviors perfectly. You've probably heard about the nature versus nurture debate in your classes before, and you'll hear it pretty much in every topic of psychology. So there are a lot of different factors, and the book goes into detail about how there may be some genetics, some hormonal, some environmental factors, but overall, we are just really at the initial stages of being able to understand how sexual orientations develop. And I think that's a really important takeaway. The book talks about 3 types of DSM diagnosable disorders. There's sexual dysfunctions, gender dysphoria, and paraphilia is covered in chapter 9. So we'll start with first going a little bit deeper into understanding sexual dysfunctions. Sexual dysfunctions can happen to all different types of people and in all different types of relationships. Just like the disclaimer I gave at the beginning, a majority of what's going to be discussed is sexual dysfunction in the context of a heterosexual relationship, or a sexual relationship between someone who identifies as a man and someone who identifies as a woman. But sexual dysfunctions can occur in all different types of partnerships, of course. Sexual dysfunctions broadly include difficulties with desire, arousal, and orgasming. Additionally, experiencing pain during intercourse or penetration can lead to additional dysfunction, particularly for women or people with vaginas. Having these types of difficulties don't necessarily mean that you have a sexual dysfunction. Typically, these types of difficulties have to be present for at least 6 months in order to make an official diagnosis. And they also have to be associated with severe impairment or distress in order to be considered a disorder. So if someone is having difficulties with arousal for a month, they probably wouldn't be diagnosed as having a sexual dysfunction if they're having this problem, but it doesn't bother them. And it's only been a month. So you really have to look at all the different criteria, just like all the other disorders covered in the course. So let's do a quick practice question. Jamie is frustrated because she has difficulty getting aroused last night with her partner. Usually Jamie has no problems getting aroused, but last night she did. Does Jamie have a sexual dysfunction, or does the information we have suggest that Jamie has a sexual dysfunction? Why or why not? So just take a minute, think that over. You can pause this video if you want a little bit more time to sort of sort through your thoughts. So I'll give you a second to pause it if you need to. All right, so if you're coming back or if you didn't pause, we'll just try to talk about this now. So probably not, right? And that's because of the information that we just talked about. So sexual difficulties happen. They happen to most people. And they happened last night to this theoretical person, Jamie. That doesn't necessarily indicate that a person has a sexual dysfunction, unless there's evidence that someone has been significantly impaired or distressed by this, and for a long period of time, more than just one night, it wouldn't be relevant to give this diagnosis. So pictured here is the human sexual response cycle. This outlines a sequence of events that people go through, from desire to acting on sexual impulses with another person or solo, to orgasming, and so on. And when we talk about there being sexual dysfunctions, we usually isolate where that disorder or where that difficulty is arising. So at what stage of the sexual cycle? So let's kind of walk through this cycle together. The first phase is the desire phase. And this is when urges start to develop. This could come from sexual cues or a fantasy that a person is having. And the next stage is the arousal stage. And this represents all of the pleasurable psychological and physiological changes that occur as people are engaging with their sexual urges. You can think of things like increased blood flow to the penis, increased blood flow to the pelvic region, vaginal lubrication. These are all examples of changes that might occur at the arousal stage. The next stage is the plateau phase, and it's a brief period that occurs before an orgasm. And in the orgasm phase, it can look differently depending on what type of body parts you have. It might look like an ejaculation in biological males. It could look like vaginal contractions in biological females. And again, the purpose of understanding this pattern or this cycle of events is to identify at what stage sexual dysfunctions are occurring for a person. So is someone having trouble at the arousal stage? Maybe they're having trouble maintaining arousal. Is someone having trouble at the orgasm phase? Maybe they have no problem, feeling a sense of desire and then acting on it and getting all worked up, but they just can't orgasm. So understanding this cycle helps researchers and clinicians sort of pinpoint where the difficulty is arising. Although some people may think that sexual difficulties are very stigmatizing, and that's fair. The reality is that sexual difficulties are extremely common in the population, and they're very much not always a cause for concern. Research suggests that about 40% of men and 60% of women experience these types of difficulties on occasion. A silver lining to this is that these difficulties, research shows, they don't actually detract from sexual satisfaction that these men and women are reporting. And I want to remind you all that in order for something to be categorized as a sexual disorder, it has to cause some type of significant distress or impairment. So if people are having these difficulties, for example, maybe someone just isn't interested in having sex for a long period of time, but they're not distressed by it, it wouldn't be categorized as a sexual disorder. So they're very common and not always a cause for concern. One really interesting point to note is that men and women experience almost parallel versions of most dysfunctions. Both men and women can have difficulties with desire, difficulties with arousal, difficulties with orgasm. However, unique to women or people with vaginas, there can be significant difficulties that involve pain during penetration, and we'll talk about that. When classifying different sexual dysfunctions, psychologists differentiate between dysfunctions that a person has had for their entire sexual life versus dysfunctions that come up after normal patterns have already been established. So you can think maybe someone's just had a very low sexual desire their entire life, or maybe someone had a higher desire their whole life, but over the past year, it's taken a huge dip. So psychologists differentiate between that. They also differentiate between a generalized dysfunction or dysfunctions that occur every time a person has sex or engages in some sexual act versus situational, where dysfunction might only occur at a particular time or with a particular partner. And of course, because many medical conditions and treatments can have an impact on sexual functioning, psychologists consider both the psychological factors that contribute to a dysfunction, as well as the medical factors that could be contributing to a dysfunction. So the first dysfunction that we're going to go into detail about is male hypoactive sexual desire disorder. And I know these are a bit of a mouthful, long names. Hypo, though, usually means less. So this can help you remember that a hypoactive sexual disorder is referring to a disorder in which there is less of something than there might typically be. And in the case of this disorder, men with this condition have little or no interest in any type of sexual activity. This means that there's very little masturbation, sexual fantasies, or engagement in sexual activity. Now, this doesn't necessarily mean that a man with this disorder is not having sex. It simply means there's very little desire present for sex. And the textbook gives an example of how a person might be engaging in sex with a partner, but it doesn't mean that they're having a high or a normal level of desire overall in their day to day life for themselves. They could just be having sex with their partner. And for both men and women, disorders at the desire stage are relatively common, with half of all people who go into a type of sexuality clinic seeking help specifically for low desire. And overall, the estimates are that roughly 5% of men suffer from low sexual desires. And this estimate tends to increase with age. In order for a man to be diagnosed with hypoactive sexual desire disorder, he must meet these DSM criteria. This includes having persistent difficulties in sexual desires. And this is a little bit subjective. And a clinician has to take into account a lot of factors that affect sexual functioning, such as age or the context a person is living in. And these symptoms also have to be present for at least 6 months and cause clinically significant distress in an individual. Lastly, that sexual dysfunction should not be better explained by a non-sexual mental disorder or as a consequence of severe relationship distress or some other substance or medical condition. So some of what is in this slide currently and what I'll show you later is paraphrasing or taking just bits of the DSM. Sometimes I won't even show you every single criteria. I'll just outline what the main points of the disorder are. So feel free to refer to the textbook if you want to see like everything written as it is in the DSM. Now let's switch gears and talk about a parallel dysfunction in women. Notice this dysfunction is combining both the desire and the arousal phase. And so this is when women experience a lack or significant reduction in their sexual interest and their ability to get aroused. This can manifest in a variety of ways, including reduced sexual interest, reduced sexual activity, fewer sexual thoughts, reduced physiological responses, like there not being as much swelling or lubrication occurring at the arousal phase. The symptoms should last for at least 6 months typically, and typically to get a diagnosis, this will be causing some type of distress or impairment to the individual. And just like with the other disorder, the sexual dysfunction cannot be better explained by a non-sexual mental disorder, relationship distress, or other substance or medical conditions. Okay, so we're also going to look at an arousal disorder now for men, and this is erectile disorder. You've probably heard of this disorder. It's oftentimes called ED. It's very popular in like the media and the news, so some of you may be familiar with it. But this dysfunction is when a man has difficulty achieving or maintaining an erection. Usually with this disorder, sexual desire is intact. So it's not that a man isn't getting aroused or isn't wanting to have sex or engage in sex. It's just difficulties with, again, achieving or maintaining an erection. This is actually the most common problem among men who seek treatment at sexuality clinics. And the prevalence rate for this type of a dysfunction increases with age. So 60% of men over the age of 60 experience erectile dysfunction. So it's very common. And of course, just like the other disorders, it has to meet criteria beyond symptomology. So it has to be present for 6 months or more. It has to cause some amount of distress or impairment, and it can't be better explained by other factors. So if we return to the sexual cycle again, we just covered dysfunctions at the desire and at the arousal stage. And now we're going to turn to disorders that occur specifically at the orgasm phase. Women with female orgasmic disorders have difficulty in orgasming that can look like a delay or just an overall difficulty with reaching orgasm, or it could be just reduced intensity of orgasmic sensations. Importantly, these types of symptoms cannot be explained by other factors, just like the other disorders, like relationship distress or life stressors. And although we don't have data about exactly how many women have this disorder, we do have data on how many women experience symptoms related to this disorder or just report having difficulty achieving orgasm. It's estimated that 1 in 4 or 25% of women have significant difficulties achieving orgasm. So very common. And again, I'm going to sound like a broken record, but that's just the case with diagnosing psychological disorders. Like everything else, you are looking for things like, has it occurred for a long period of time? Does it cause distress? Are there other explanations or other factors? Now we're going to talk about an orgasm disorder that affects men, and this is premature ejaculation. Premature ejaculation is ejaculation that occurs within 1 minute of penetration, but importantly, before it's desired by a man and by his partner. And this is very common in men, with 20% of all men meeting the criteria. It should be noted that an occasional early ejaculation is totally normal, but it's when it's happening consistently that it might begin to meet this criteria. Usually, psychologists find this diagnosed in younger men who are less experienced with sex, and this prevalence tends to decline then with age. And like all other disorders, we look for how long has it been going on? Is there significant distress or impairment? And are there other explanations? We've talked about desire, arousal, and orgasmic disorders, but there's also sexual pain disorders. And women can have what's called genitopelvic pain / penetration disorder. And for convenience sake, I might refer to it as a pain dysfunction. So some women may have a very high sexual desire. They may be able to become very aroused, but then the difficulties begin with penetration. Women can have pain or just the fear and anxiety about there being pain, or an intense tensing of the pelvic floor muscles in anticipation of penetration. Types of symptoms or reactions to penetration in this nature can occur even outside of a sexual context for women with this dysfunction. So these symptoms might occur during things like a gynecological exam, or when a woman is inserting a tampon during her menstrual cycle. And again, we look, how long has this been happening? Is there distress or impairment? And are there other explanations? All right, so now we're going to talk about how we assess sexual behavior. So we talked about the diagnostic criteria, but what happens when psychologists begin to work with a person or really assess sexual dysfunctions? So the first thing is usually like a comprehensive interview where a psychologist takes a detailed history of sexual behavior, lifestyle, and associated factors. Typically, psychologists will use a survey because people tend to be more comfortable talking about sex or their sexual difficulties if it's something that they're just writing down in a survey or circling a number of versus verbalizing it out loud. And then another thing is a medical examination is usually done, and this is to rule out other potential causes of the sexual dysfunction. For example, a lot of really popular medications, like those prescribed for anxiety or depression, can cause sexual dysfunction. You might have heard that, like antidepressants, making it difficult for people to orgasm and things like that. So you really want to rule out these other factors as a starting point. To measure the ability for a patient to become aroused, you'll probably do some type of psychophysiological evaluation. One option is a penile strain gauge, and this measures erections. So when changes are going on in a penis and it's expanding and becoming aroused, this can be recorded on a device, and you can display it on a polygraph. And then a similar type of tool can be done to measure women's ability to become aroused. This is a really difficult word to pronounce, vaginal photoplasmograph, and I apologize if I completely butchered that. But this is a device that's inserted into the vagina, and it measures the blood flow to the vaginal walls, which can indicate arousal. You might look at how people are reacting to erotic material as another way to assess their physiological responses. Maybe while they're hooked up to these devices, you have them viewing erotic material so you can see if their body is responding. And you can use these tools to help determine the extent and the pattern of sexual arousal or lack thereof. Okay, so what are the causes and treatment of sexual dysfunctions? Well, first of all, there are biological contributions. Things like physical diseases, medical illnesses, prescription medications, even things like drug and alcohol abuse. All of these can be biological explanations for why a person is experiencing certain sexual dysfunctions. There are also psychological contributions to sexual dysfunctions. People with sexual dysfunctions are more likely to experience anxiety and negative thoughts about sexual encounters. They may actively avoid awareness of sexual cues, so they're not really in touch with their own sexual response. These are just possibilities. An example is a man with premature ejaculation. He may tend to distract himself purposely to avoid an orgasm, but then this may lead to even lower ejaculatory control. There are also important social and cultural contributions. So the book talks about this term erotophobia, which is learned negative attitudes about sexuality. And this can come from authority figures in religions or family authorities. Maybe a person has negative or even traumatic sexual experiences, and this is impacting their sexual functioning. Deteriorating interpersonal relationships can also make it really difficult to have satisfactory sex. So looking at all of these different factors, biological, psychological, social, it's very unlikely that a sexual dysfunction is caused by just one physical thing or one social thing. It's likely that there's an interaction of all these psychological and physical factors that lead to a specific sexual dysfunction. The most simple and maybe surprising treatment for sexual dysfunction is simply education. And the book goes into detail about like a sex therapy education program that's really popular, the Masters and Johnson's psychosocial intervention. This provides typically a couple with education about sexual functioning and therapy every single day for about 2 weeks. And the goal of this is really to help decrease performance anxiety and help get a couple back on a better track for sexual functioning. So there's sensate focus and non-demand pleasuring, which are both a part of the psychosocial interventions that target reducing performance anxiety. And sensate focus and non-demand pleasuring, that's when you have sexual activity with the goal of focusing on sensations, so sensate focus. So the goal is not necessarily to achieve an orgasm. In fact, at the beginning, you're instructed that's very much not the goal. This can mean just a couple exploring and enjoying each other's bodies through touching, massaging, hugging. And at first, a therapist will not even have a couples touch. So it starts off not even touching, and then touch highly sensitive areas. And then couples touch, but there's no penetration involved. And it just kind of builds up and escalates over the course of therapy until it can get to full-blown penetrative sex. And this treatment is extremely effective for men with premature ejaculation and mostly effective for men with erectile dysfunction. So there are other sex therapy treatments that have been developed. One is the squeeze technique for premature ejaculation. And this is when a penis is stimulated nearly to a full erection, but then it's sort of squeezed at the top to reduce sexual arousal. And this process is repeated and repeated over and over again to help a man develop a sense of control over arousal and ejaculation. Masturbatory training is used for female orgasm disorders. And it's pretty much what it sounds like. A couple typically will go in, and a woman will get training on how to masturbate and learn over time how to communicate her desires and what's turning her on and what's helping her orgasm, and the partner can learn about women's arousal better. Other treatments include exposure to erotic material, which can be helpful for low sexual desire problems. But what if a woman is experiencing pain during sex? Well, then comes in the use of dilators. This is where a woman and her partner, potentially, or a woman alone, it doesn't matter, can insert dilators that gradually increase in size into the vagina. And dilators are basically like tube-shaped things. I don't have one physically, but we can just use this lipstick, for example, and it just gets bigger and bigger and bigger, and you can practice having it inside you and getting used to the sensation and getting comfortable with it. And I will show you a video on the next slide of what real ones actually look like. But the goal of the process is that when the largest dilator is able to be comfortably inserted, then it's more likely that a couple can have penetration with a man's penis and have it be comfortable and not painful for the woman. So now I'm going to show you a clip of what these look like and how people with vaginas are instructed to use them.
Hey friends, it's Kristen from Action Potential, and today I want to explain what a vaginal dilator or a vaginal trainer is used for. So for women who have difficulty with the flexibility of their vaginal opening, oftentimes this can be a really fantastic solution to help improve that flexibility. Women who have a limited vaginal opening will have pain with things like intercourse, putting in a tampon, or maybe even just going for a vaginal exam, either with a PT or an OBGYN. Certainly that restricted flexibility around the vagina can be very embarrassing. It can also be really painful and limit you from being able to do the things that you need or want to be able to do. So a vaginal trainer is a nice solution to help improve that flexibility. I've put a couple of them out here, and these are a variety of the different sizes, but what I didn't have enough room for is that they go all the way down to a very small size. So this is a tool that can be used for someone with a very restricted vaginal opening, as well as can progress all the way up to a pretty hefty girth to help prepare you if you do have a partner with a larger size, or you need increased vaginal flexibility for something like childbirth. The way that a dilator works or a trainer works, you can do it both passively and actively. To get a passive stretch, you would actually just insert the dilator into your vagina and leave it there. You can throw on your favorite Netflix movie, or read a book, and essentially by having that inserted into your vagina, it will passively start to increase the flexibility. These are very flexible and comfortable and made from a nice soft silicone, so they are something that you can insert and leave in. My preference for a vaginal trainer, however, is to use it more actively. To do that, you would insert it into your vagina, and then by holding the end, you can actually actively massage the bottom side of your vagina to help with expanding the flexibility. So certainly this can be done preventatively to prepare you for something like a doctor's appointment, or it can be done as a way to get ready to have intercourse. So oftentimes I'll encourage people to go and do a little bit of trainer work before having intercourse with their partner so that they have reduced pain. Over time, the goal is to help use these trainers or dilators to increase the flexibility of the vagina so that it's able to tolerate whatever is necessary for your activities. Again, they range in size. I often will tell people if they are having pain with intercourse, they can actually figure out what size they need to go to by measuring the girth of their partner, simply by placing their hand around their partner and then using that to compare to the size of the trainer. So certainly some options that we could work with you on to help figure out kind of what your goal is for that use. Trainers are available through Amazon as well as through individual providers. My particular preference.
Okay, so I'll stop right there. You can definitely look into those further. All right, so switching gears now to medical treatments for sexual dysfunction. So things you're probably not going to buy in an Amazon store or see a therapist for. You might see a medical professional for these treatments. One very popular, and I'm sure most of you have heard it before, is Viagra. So this is a medication that helps men maintain erections. But the book goes into detail about how men typically don't find this very satisfactory, and it can come with side effects like severe headaches. Another option is injecting vasodilating drugs into the penis that increase blood flow to the penis and help men maintain erections. But of course, injecting something into a penis can be painful. So there's that. There's also penile prosthetics or implants that can look like a silicone rod inserted into a penis, and then they can be bent into positions appropriate for intercourse. There's vacuum device therapy, which is an external pump that creates a vacuum in a cylinder placed over a penis to help draw blood to the penis and then trap it. With so many different types of treatments available for men with sexual dysfunctions, you would think there would be a lot of medical interventions available for women as well. Unfortunately, this has not been prioritized, and the research done for treating women's sexual dysfunctions medically is still very much in its infancy. There is some preliminary evidence to suggest that there's almost like a Viagra for women, that type of a pill that could be effective in treating women's sexual dysfunctions, but it's too early to tell. Okay, so now we're going to talk about paraphilic disorders. So we sort of wrapped up the main key information when it comes to sexual dysfunction, and now we're going to talk about paraphilias. If you've ever seen online videos where they've talked about maybe like atypical sexual attractions, like someone sexually attracted to balloons, or a woman who's sexually attracted to bridges or building, you know that sometimes people are just aroused by things that may be seen as abnormal or inappropriate, such as everyday objects, or in some cases, animals. When the source of a person's arousal causes them distress, impairment, or harm, this can be diagnosed as a paraphilic disorder. So, paraphilic disorder is misplaced sexual attraction and arousal focused on inappropriate people or objects to the extent that it causes a person distress, impairment, or harm. If a person is, say, attracted to balloons and it doesn't bother them and it doesn't hurt anyone, this probably would not be a diagnosable paraphilic disorder. And oftentimes people with paraphilic disorders also have other types of psychological disorders. So there's that comorbidity with disorders such as anxiety, mood, or substance use. There are a lot of different paraphilic disorders discussed in the DSM. So we're going to go over them in greater detail, but here's just a list of the disorders. Okay, starting with fetishistic disorder. If someone has a fetishistic disorder, this means that they have a sexual attraction to non-human objects. This can be a very specific object like a shoe, or it can be specifically tied to tactile sensations, like feeling things made of rubber. Someone with this disorder has most or all of their sexual desire and urges focused on this object. So here's the specific criteria for fetishistic disorder. So again, we have that time criteria of at least 6 months, recurrent and intense sexual arousal for non-living objects. They cause distress or impairment in some ways. And they make an important distinction that the fetish objects are not limited to articles of clothing used in cross-dressing or devices designed for the purpose of tactile genital stimulation, like a vibrator. And yeah, so those are the criteria for fetishistic disorder. Now for frauderistic disorder. A person with this disorder seeks sexual gratification by rubbing up against unwilling others. And this often occurs in settings like crowds or settings where a victim cannot escape. You can think of like a crowded elevator or a trip on a subway. A person might use those settings to rub up against an unwilling person. And just like with fetishistic disorder, you're looking for it to be present for a period of time, over 6 months. And in this case, you're rubbing up against a non-consenting person, which is an important point to make. Then you have voyeuristic and exhibitionist disorders. And I would say these are pretty commonly displayed, like in the media and TV shows, where voyeurism is when you're observing someone who doesn't know that you're watching them undressing, being naked, or having sex. And then exhibitionism, that's when you're exposing yourself to unsuspecting strangers. Both voyeuristic and exhibitionist disorders have to do with unsuspecting individuals. So again, for voyeurism, a person is finding sexual gratification in secretly watching another person, like undressing, naked, having sex. And with exhibitionism, a person is finding gratification by exposing themselves to an unsuspecting other. And with both of these types of disorders, excuse me, the thrill and the risks involved are part of what the person finds arousing. Another type of paraphilic disorder is transvestic disorder. And this is when a person finds sexual arousal specifically from the act of cross-dressing. So a lot of people with this disorder may be married and let their spouse know about this, so it's not hidden. And I think it's really important to state that cross-dressing or even sexual arousal with cross-dressing is not pathological. It's not a disorder. It's only considered a disorder if it causes significant distress or impairment to an individual. So if a person is getting aroused with the act of cross-dressing and it's causing them distress, it's causing them disparament, and it's not going away for a long period of time, then this might meet the criteria. Sexual sadism and sexual masochism. These are other types of paraphilias, and they involve either inflicting pain or humiliation on others or receiving pain or humiliation onto oneself. So sadism is a form where a person attains sexual gratification from inflicting this on others. So inflicting pain or humiliation on others. And masochism is a form where you attain sexual gratification when you receive pain or humiliation. And I know you've heard me say this a million times in these lectures, but enjoying these things is not inherently disordered. A person has to be distressed or impaired or acting on these urges with an unconsenting individual in order for this to be diagnosed as a disorder. Okay, so probably most of you have heard of pedophilia, and this is the paraphilia that involves sexual attraction to children aged 13 or younger. A vast majority, and by a majority, I mean like 90% of people with this disorder are men. It's extremely rare, but it's not unheard of for it to be present in women. And some important findings about pedophilia is that male pedophiles usually are not aroused by adult women. So you can use like the same physiological techniques that we talked about earlier to measure arousal. And you can see that men with this disorder oftentimes just don't get aroused by adult women. And also there's evidence showing that they often rationalize behavior. So perhaps someone with pedophilic desire is telling themselves that it's actually an act of kindness because you're teaching a younger person about sexuality if you're engaging with them. So where do all of these different types of paraphilic disorders come from? We know from case research that oftentimes people with paraphilic disorders have difficulty forming normal relationships. So maybe they don't have a lot of appropriate sexual experience, or they've had a great deal of relationship difficulties in childhood or in adolescence. And if you've ever heard of conditioning, this is when you associate two things together. This may also be another explanation for how paraphilic disorders develop. If someone's early sexual experiences include something like a boot coming up a lot in sexuality, in sexual fantasies, or in erotic material, and then they start to form strong associations between that object, that boot or that shoe, with sexual gratification, then they may then see that object and become aroused. Interestingly, clinicians have noted that people with paraphilic disorders also tend to have very high sex drives. And by high sex drives, this means like masturbating 3 or 4 times a day or more. And the reasoning behind this, they speculate, may be that people are trying to suppress the unwanted or not socially acceptable thoughts that they have, and that this is having almost like an opposite or rebounding effect, where it's actually increasing the frequency and the intensity of their desires, and thus leading to more sexual urges. And just like we saw with general sexual dysfunctions, the treatment of paraphilic disorders may include a type of psychosocial intervention. These types of interventions can be like behavior therapy, where a therapist works with a patient to change the associations they have in their head between an inappropriate object and try to make it a little bit more neutral. And one method of making new associations is through covert sensitization. And this is where you have a person imagine some like really negative consequence that could happen as a result of paraphilic behavior, and then train that person to begin to associate the negative consequences with paraphilic behavior. And in addition to making negative associations between the unwanted behavior and consequences, you can at the same time work to strengthen a desired pattern of arousal. With orgasmic reconditioning, a patient masturbates as normal, so maybe even with their normal paraphilic erotic material, but then right before they orgasm, they substitute a more appropriate or desirable fantasy. This strategy helps people build more desire for that appropriate fantasy. As it's repeated over and over again, they'll begin to want that appropriate stimulus earlier on in the sexual experience. There's a lot of mixed evidence when it comes to how effective these treatments can be, specifically for sex offenders, though. And if you look at outpatient offenders, psychosocial treatment can be helpful for a lot of individuals, like estimates ranging from 75 to 95%. But if you look specifically at men who rape, they have the lowest success rate with this type of psychosocial treatment. When it comes to medical intervention, there are medications used to treat paraphilic disorders. One such medication is referred to as chemical castration, and it's reserved for dangerous sexual offenders. It reduces testosterone and therefore sexual urges and fantasies. But the thing about these types of drug treatments or chemical castration techniques is that the original paraphilia fantasies and arousal typically return as soon as a person stops taking the drug. All right, so now we are going to switch topics from talking about paraphilias to talking about gender dysphoria.
Dysphoria, a term many don't know but may still feel. It's basically the disassociation or depression someone may feel towards parts of their body. This can apply anywhere from voice pitch or the chest region to feet size or height as a whole. And when someone is faced with a person misgendering or deadnaming them, it's just another reminder of their dysphoria. A lot of people don't understand what dysphoria feels like, and I understand that. Sometimes it's difficult to see a situation from another's perspective. In other words, dysphoria feels like wearing your right shoe on your left foot and your left shoe on your right foot, but never taking them off. So it's uncomfortable, and you can't be your true self. Like, how could you run or play a sport to your best ability when you have shoes on like that? And maybe you forget about it for a bit while sitting or getting distracted, but once you start walking, you'll notice it all over again. That being said, everyone feels dysphoria at different levels. While one might only bother you a bit, another might feel like being shot with an arrow. Besides the obvious, there are a few ways to help deal with dysphoria. Definitely find someone you can talk to, but also find time for yourself. Doing hobbies or sports that distract you. Heck, even drawing these animations help me. And just remember, you aren't alone when it comes to feeling dysphoria. Take a deep breath and know it'll be okay. It's difficult to handle sometimes, but it's not impossible to overcome. To fix your shoes and walk proud.
All right, so defining gender dysphoria. Gender dysphoria is when a person experiences psychological dissatisfaction with their biological sex that decreases their sense of identity as a man or as a woman. And the primary goal is not sexual arousal, so it's not a sexual dysfunction by any means. The goal is to just live life as the opposite gender. And it's not very clear what causes gender dysphoria. Genetic and hormonal underpinnings have been studied and suggest that biological causes may be a part of what is contributing to this experience. It's so important to really drive this point home, though, and that's that fluid or cross-gendered identity is not a disorder. It only becomes a disorder when it causes distress or when there's significant impairment. So when a person is experiencing extreme distress about not matching the gender they were born with or the sex they were born with, then this diagnosis may be relevant in helping them access the appropriate care. What does appropriate care look like for individuals experiencing gender dysphoria? There is an ordering starting from usually the least intrusive to the most intrusive treatment. A psychologist might start with therapy and education programs, then potentially hormones, and then finally sex reassignment surgery. With this type of a surgery, a person changes their physical anatomy to be more consistent with their gender identity. It's not easy to get this surgery, and there are a lot of criteria or hoops that our system forces people to jump through in order to get this type of surgery, including being stable in all areas of their life or in a lot of areas of their life, living as their desired gender for several years prior, typically being diagnosed with this dysphoria and other factors. but most people actually really benefit from getting this procedure. And it's estimated in recent years that about 90% of people with gender dysphoria who have had sex reassignment surgery were later satisfied with that decision. All right, so I'm going to end today's talk with a summary of sexual and gender identity disorders. So we first talked about sexual dysfunctions, how they're very common, and how we typically look at problems occurring at different stages of the sexual cycle, such as problems at the desire, arousal, or orgasm stage. With paraphilic disorders, they represent inappropriate sexual attraction. So like inappropriate attraction to an object or to a non-consenting individual. There are psychosocial and medical treatment options that are available for people. Typically a comprehensive assessment or treatments that treat multiple aspects of where a disorder might be coming from are best, because there's usually not just like one underlying contributing factor. And gender dysphoria is the experience of being trapped in the body of the opposite sex. And people with gender dysphoria benefit from treatment that allows them to get closer to living in the body that is appropriate for them. All right, thank you so much for listening to my lecture on Chapter 9 of the Abnormal textbook. And if you have any questions, I'll put my email on the next page and you can feel free to reach out. Thank you.